Good morning everyone. Today we are going to discuss about a topic called trigeminal neuralgia. So the basics about trigeminal nerve is the largest cranial nerve. It is the number 5 cranial nerve. It emerges from the side of pons near its upper border by small motor and large sensory roots. Sensory root is large, which innervates head and face, and motor root innervates the masticatory muscles. And the three major branches are ophthalmic, maxillary, and mandibular nerves. And ophthalmic it distributes the by name itself distributes over the eye and its related contents. Maxillary nerve distributes maxilla and its related contents, and mandibular nerve it distributes the lower jaw, cheek, and also up to scalp, preauricular areas like that. And it carries the information like touch, temperature, pain, and proper pressure from the face and scalp to the brainstem. So these are all the branches which are related to the trigeminal nerve. And trigeminal neuralgia, it is defined as sudden, usually unilateral, severe, brief, stabbing, lancinating, recurring pain in the distribution of one or more branches of fifth cranial nerve. That is, pain sensation in the distribution of the trigeminal nerve is called trigeminal neuralgia. In the history, in 1977, John Locke, a noted American physician philosopher, accurately identified the major clinical features of trigeminal neuralgia. In 1756, the French physician Nicolas André gave the name Trigeminal to the disease, commenting that it is exclusive and distinctive from all the diseases. And in 1770, John Fothergill he established and outlined the major symptoms of trigeminal neuralgia, and the trigeminal neuralgia is also known as Fothergill's disease. Now, the etiology, these etiology are only hypotheses; they are not yet proven, and so it is called as enigma. Now, vascular factors like ischemia causes demyelination of the nerve, which results in pain pain in the course of supply of the nerve, and mechanical factors like pressure from aneurysms of internal carotid artery, which results in erosion of the intracranial fossa, which causes pulsatile irritation of the trigeminal ganglia. And also another theory is that anomaly of superior cerebellar artery, it lies in contact with sensory root of trigeminal ganglion, which results in anomaly, and it causes demyelination of the nerve, thereby causing that neuralgia. And dental etiology is like loss of teeth and degeneration of the nerve proceeds proximally to involve the nucleus. And infections like various granulomatous and non-granulomatous infections involving fifth nerve. Multiple sclerosis is particularly correlated with the trigeminal nerve because of the sclerotic plaque located at the root entry zone of trigeminal nerve. And Peter's ridge compression, because the compression of the dural foramen causes Peter's ridge compression, which thereby results in trigeminal neuralgia. And post-traumatic neuralgia, like following the neuromas because of any trauma or injuries. And intracranial tumors like meningiomas of cerebellum mountain angle, Metcalfe's cave, arteriovenous malformations, aneurysms, and this causes the compression of the vascular pedicles over there, which impinge on the nerve. And viral etiology like herpetic lesions can result in trigeminal neuralgia, particularly in the elder patients. Like a general characteristic, it causes in 4 people out of 1 lakh people, and mainly occurs at the middle age or later the 5th or 6th decade, and it has 58% in females. The female predisposition is present, and it has predilection for the right side of the face. And here mandibular nerve is mostly affected, followed by maxillary and ophthalmic nerve. And in these clinical features are more important because these are the diagnostic features of trigeminal neuralgia. Here, the pain will be sudden, unilateral, intermediate paroxysmal, sharp shooting, stabbing, lancinating, brief periods, and it can be also triggered by touching the trigger points which are distributed in the course of the nerve, and it radiates that point and distributed to 1 or more branches. And pain usually confined to only 1 branch, and it is unilateral only. So it doesn't cause a midline. And pain is of short duration. That's the pain occurs in amount of episodes in brief periods. And during attack, patient grimaces with pain, clutches his hands over the affected sides, and he stops all the activities. And it also occur while routine activities like shaving, eating, salivating. And people often call trigeminal stick dorylix because of characteristic muscle spasm that accompanies the pain. And also male patients while shaving and other because of poor oral hygiene can result with trigeminal neuralgia. Occasionally, a cold breeze or cold attack to the face can result in trigeminal neuralgia. Paroxysm occurs in cycles, each sizing lasts for weeks and months, and there will be no attacks during the sleep. Patients lead poor quality of life due to pain, and also they have fear of unpredictable attacks, which can be leads to mental debilitation and and life depriving. This condition can lead to irritability, severe anticipatory and anxiety for anticipatory attacks due to the pain, depression, life-threatening malnutrition, and suicidal depression is also common. And diagnosis can be done by a criteria called white and sweet criteria. In that, the first point is the pain is paroxysmal. That is, there is periodic attack in brief periods, and also there is repeated attacks. And also, pain may be provoked by touching the trigger zone by light touch or during savings also. And the pain is confined to the distribution of the trigeminal nerve. The pain is unilateral, as we discussed earlier. Pain is rarely bilateral. And clinically, sensory examination should be normal. First of all, we should the neurological sensory testing. In the testing, if it is negative, we should consider the pain as neuralgic pain. If it is in the course of the trigeminal nerve, it is considered as trigeminal neuralgia. And also there are two classifications that is given by International Classification of Headache Disorders. The first one is classical trigeminal neuralgia, and next one is symptomatic trigeminal neuralgia. In classical trigeminal neuralgia, the pain is idiopathic. That is, we don't know why neuralgia is happening. Although some of the cases are considered because of vascular compression, we discussed earlier, due to compression of the internal carotid artery or cerebellar pointer angle. And symptomatic TL has the features which are supported by other disease process such as multiple sclerosis, cerebellar pointer angle tumor. And diagnosis mainly by clinical features and also the sweet criteria. And trigger zones are present where along the distribution of trigeminal nerve. It can be present in oral mucosa or also on the skin. So here the TN is confined to only the region of the distribution of the trigeminal nerve. It can be evoked by light stimulus, and each attack has similar quality, intensity and location also. And also here the sensory neurological testing or examination is normal. And treatment is divided into medical and surgical. In medication, the first line of treatment is carbamazepine, phenytoin, which can be used for the epilepsy, gabapentin for neurological disorders, and baclofen. As the disease progresses, the pain increases, so that it can lead to intolerable side effects because of these drugs. Each patient or sufferer has different tolerance to medications and pain, so it can be given according to the dosage and medication to which the patient can be controlled. And phenytoin was the first drug which is introduced in 1942 for that medical treatment of trigeminal neuralgia. And next in 1962, carbamazepine became the most used drug for the trigeminal neuralgia. And also anticonvulsants are used for the reducing the hyperactivity of the trigeminal nerve in the nucleus and brain stem. In treatment, it is initiated with the 1 hour drug like tegoprol and neurotin, and dosage can be increased and it can be related according to the tolerance of the patient. Medical therapy is ineffective for most of the patient in trigeminal neuralgia. Then surgical treatments are considered. Here there will be interruption of pain pathways between center and periphery. The first one is alcohol block in the peripheral nerve section or avulsion, electrosurgery and cryosurgery. Yeah, and other procedures like selective radiofrequency thermocoagulation, Caesarean ganglion blockage, acupuncture technique, and next is psychological approaches like biofeedback, psychiatric counseling and hypnosis. Thank you.